Happy Thursday, everybody. Dr. Adam Smith, Ultimate Bariatrics, coming to you from the Fort Worth office. It's an exciting time to be a surgeon. It's an exciting time to be alive. But it's funny in 30 years how things have changed surgically. And surgically in general and in bariatrics in particular, we have come a really, really long way. So when I was a resident in training, the first 2 years, everything we did was an incision. There was nothing, the only thing anyone was doing through a laparoscope were tine tubes. So in like 1989 or so, maybe 88, this guy in Nashville, Tennessee, took a gallbladder out using a laparoscope and the world changed. We took surgeries that were good surgeries but had a lot of pain and morbidity afterwards and made them more patient friendly. And so the gallbladder surgery, when we started doing them laparoscopic, went from a 3-day hospital stay to a 1-day hospital stay to eventually an outpatient procedure. Same thing happened for inguinal hernias, and then some surgeries that were really, really morbid got more patient friendly, like anti-reflux surgery. That used to be just rough, like a chest incision, an abdominal incision. Now we can do them through the laparoscope. People go home same or next day. Same happened with bariatrics. Prior to the advent of laparoscopy, all bariatric surgery was done with a big midline incision. And when you take someone that has a 50 BMI, that has this much room between their skin and their muscle, and you make a big old cut on them, guess what? Your risk of wound infection is high, your risk of post-op hernias is high, the pain post-op is high, and when you have upper incisional pain, you don't take deep breaths, so then you have post-op pneumonias, and the list goes on and on and on. So laparoscopy was a game changer. So still, most bariatric surgery was done open because the majority of old school bariatric surgeons were open surgeons. They weren't embracing this laparoscopic technology. And it started to change in the end of the 90s. And the first thing that happened was this guy out in California had the nerve to do a gastric bypass through a laparoscope. And it was crazy. How can you do that? You know, well, he did. And it was really interesting in the early days. If you wanted to go get trained on that, you had to buy this piece of equipment that was like really, really expensive, called ESOP, I think was the name of it. And if you bought an ESOP for your hospital, you got to go learn how to use it out in California and learn how to do the procedure, and then you could come back and do that. And some people did that, but the majority of bariatrics was still being done open. And then in 2001, this little dude was approved by the FDA, the lap band. And it changed a lot of things because people didn't want a gastric bypass. They didn't want a big old open surgery, but they needed something to help them with their weight. So this little device, which is still a good, important tool in our arsenal, was approved by the FDA in 2001. It was placed laparoscopically. Originally, we kept all these patients in the hospital for a couple days. Of course, now it's done as an outpatient. But it was funny because a lot of the traditional big time, you know, I call them the talking heads, the guys that go do all the lectures and are at all the ivory towers, they didn't want anything to do with this thing. Well, it's because they sucked at laparoscopic surgery, a lot of them. It wasn't that it was a bad surgery, it was they weren't very good at it. So the company that brought this to market finally said, you know, it might be easier to take a surgeon that's good at laparoscopic work and teach him how to take care of a lap band patient than it is to convince these old, hard-headed, terrible laparoscopists to put this thing in correctly. And the lap band shot to the ceiling in popularity because people wanted it, and it just changed everything. And then well, if I'm going to do a lap band, I might as well do the bypass through the laparoscope too. So I was not doing bypass open, so I went and did a mini fellowship and took time away from my practice and went and learned how to do the bypass through the laparoscope. And it was fine. I mean, it was a natural transition for me. So for several years, you had two choices. You had the band or the bypass. And there were still some other surgeries being done. We had this surgery called it was originally called the Scopanaro procedure, then it was modified and its eventual name became the biliopancreatic diversion duodenal switch, which we still call the nuclear option. That's one of my young colleagues' favorite surgery because it has the highest percentage of weight loss, no doubt. The highest percentage of weight loss. But it was a difficult surgery to do laparoscopically. It was quite difficult. So we decided to do it in two stages. We did the top half, or the stomach part, with the intent of coming back a year later to do the bottom part. Well, 60% of the people that did the top part never came back for the bottom part because they were happy with their weight loss and they didn't want any more surgery. So that's how the most popular surgery that we do today was born, the laparoscopic sleeve gastrectomy. It's the top half of a DS. So this one is by far and away the simplest laparoscopic surgery we do for bariatrics. I mean, anyone who can fire a stapler and see with both eyes can probably do this operation. But pretty straightforward outpatient procedure. You come in, you have the operation, you go home. We're removing about 60% of the greater curve of the stomach, leaving you a long, skinny stomach. We're getting rid of some of the cells that secrete the hunger hormones, so your hunger is suppressed. And we're doing a little negative reinforcement. We're taking away a lot of the surface area where refined sugar is digested. So if you consume a diet too high in sugar, you're going to pay the price. It's called dumping syndrome. Most people don't enjoy that very much. So this is the most popular operation we currently perform for weight loss. What's funny is the traditional laparoscopic Roux-en-Y gastric bypass, which we call the gold standard of weight loss surgery, has consistently remained about the same percentage of the market. It's kind of tried and true. We call it the gold standard because we've been doing it so long. When we compare data, that's what we compare to. So right now, the state of the union, could be a dirty word to some people, as it exists, the lap band is still there, but it's not the most popular thing we do. The sleeve is the most popular. The bypass is probably the second most popular thing we do. And we still do the duodenal switch, or the biliopancreatic diversion duodenal switch. But we now have a new player that is so new I don't even have a good picture of it. And it's called the SADI. Some people call it SIPS. And it is a simplified version of the duodenal switch. So instead of doing all this rerouting and Roux-en-Y configuration, we go down here counting back about 300 or so centimeters and bring this loop of bowel up and sew it right here to the first part of the intestine. We combine that with a sleeve gastrectomy because if you don't do the sleeve gastrectomy, they'll get bleeding ulcers. It has weight loss not quite as aggressive as the duodenal switch, but more aggressive than the sleeve and the bypass, generally speaking. It's really gaining momentum. It took a while to take off, took a while for people to embrace it and start doing it. It's really technically a much simpler surgery than the DS, and maybe even simpler surgery than the bypass, although, you know, when you've been doing them for 30 years, they're all pretty simple to you. So ask about that if you're coming in for a consult, especially if your BMI is over 50 or over 45 or so. That might be a consideration for you. Remember, when we talk about outcomes in bariatric surgery, 80% of your outcome is dependent on what you as the patient do, and only 20% is what I as the surgeon do. That's what makes the difference. And when we look at statistics and weight loss, remember, statistics only apply to groups of people. They don't apply to individuals. We can get an idea of what to expect from statistics, but they're not applicable to a unique individual. We're all unique human beings. We all react differently. We all behave differently. So really a lot of fun stuff. And now all of these surgeries are being done through the robot. And it's funny, when we transitioned from open surgery to laparoscopic surgery, I had some trainers that said, I'll never take a gallbladder out through a laparoscope. And I found myself early on in the robot days saying, why should I use a robot when I can do just as good laparoscopically? Well, I find myself guilty. I have embraced the robot. I like the technology, and I've gotten way over the learning curve where I'm like pretty doggone good at it. And it can be a game changer, and I think it's going to continue to be a game changer down the road. It just allows us to do things with a little more finesse than what we can do through a laparoscope in some cases. Pretty much all the places we go to has a robot, so it doesn't matter where you have your surgery. If it's appropriate for the robot, great. There's some surgeries that it doesn't make sense for, but like especially our bypasses and our DSs, we're doing most of those through the robot these days. So anyway, that's a lot of stuff about surgery. We've come a long way. Things are continuing to expand, and I think you're going to see some more surgical innovations coming down the pike, and you're going to see a lot more medical innovations. We got a lot of more medications that can help us coming down the pike as well. So stay tuned. If you're interested, follow us at ultimatebariatrics.com, ultimatebariatrics.com, or call or come in and visit. Love to see you. Have a great week.